From a perspective from a mental health carer, how robust are your inputs? For example, my son has had schizophrenia for over 20 years, and when he gets ill, he sort of shuts down and sort of reflects it back. He knows the things not to say. I call that careful concealment. Do you have a safe loop, like a sort of a reality check built into your system to take a perspective from a carer into account? I think to improve the robustness of the inputs. Because, junk in, junk out.
Yeah, I think I've understood the question, but correct me if I'm wrong. Are we giving too much information away into the public arena so that patients might be able to say what we want to hear rather than what's actually?
There's an element of that must come into it.
Yes, it is interesting, isn't it? And in fact, when I first presented the map to fellow GP colleagues, there was a GP who turned around and said, God, put that down, because if patients see it, they'll be in presenting this and expose my lack of knowledge. And I didn't quite know how to respond to that question. Of course, we now live in the information age and Google, and there is nothing stopping anybody from Google searching and finding all sorts. And in fact, my own experience as a GP over the last 10 years is patients come in with the Daily Mail, things that they've read, snippets, magazines, things that they've read on television. I'd rather bring them to my page. I'd rather, if they are going to come and bring something, bring them the map. The amount of knowledge and the explosion of knowledge, I mean, there's about 5,000 papers a week that come out that could impact on my job as a GP. I can't possibly keep completely up to date with it, but I bet you if you've had schizophrenia, if you've got a son who's got schizophrenia, and he sees the latest map of medicine update on schizophrenia and looks at his own care and says, do you think this might be an opportunity? I'd actually thank him for that. That doesn't take away my responsibility, and this is back to the GMC type stuff, that says, well, yeah, the patient is saying what they're saying, but I'm the doctor. I've still got to confirm that what I'm seeing does fit in with the bigger picture. So there's nothing, and there is a clinical, a very important clinical role there. It's not about patients playing doctor, it's about patients bringing information. It's back to the two experts. The clinician is an expert, and the patient is an expert, and the third expert supports both of them.
I think what I'm saying is the fourth expert is the carer perspective.
I agree, completely so, yes, sorry, quite agree.
I think it's great that the NHS has got access to this, but we're now more and more delivering care in partnership with third sector, independent sector, and from my recent perspective, very much the local authorities who are part played. How do we enable them to get access to this, and is it as simple, or are there additional charges for them to be able to become registered users?
It's freely available to any organisation that has a contract with the NHS. And what we're finding, we are being approached by the independent sector. The only thing we're allowed to charge for is if they want to, want time to help assist with local pathways. But that's trivial for those organisations. So, and they also can, of course, access it or straight off the website, the NHS Trust.
And have many people sort of taken particular pathways and localised them to social need, social intervention as much as to health intervention?
That's a very good question. That's happening more and more. We found that, in fact, some of the pathways, there are a few pathways that don't get put up, that for example, the child abuse pathway, there's a lot of debate about whether that should be accessible to the public or not and so on. But by and large, there are people putting in a lot more information about social care aspects, and that's been done at a local level. We don't do that centrally unless we, say 3 organisations across the country are all localising the same way. The next release will probably incorporate that, but not a priority.
Can I just ask, if you've got the map of medicine up, do you see the national map of medicine and then the local interpretation? Can you compare?
Now, when you put your smart card in and then open up, what happens is on the desktop there's a little icon that you double click, and once you've already put your smart card in, it already recognises where you're based. So if I put my smart card in, because I work in Tameside and Glossop, it automatically brings up the Tameside and Glossop view. However, I can click on other views, so I can then see the international view, the Chester view, the London view, or whatever it might be. But the automatic default position is the area that you're working in.
My concern would be that national guidance or a national map might show organised guidance, for example, and pathways, but local interpretation might think we haven't got that resource, so we'll actually not put that on. And that doesn't give a full picture then.
Right. Before something is published as a local resource, there's a huge clinical governance process that needs to take place. And locally, clinicians, if they're going to choose to do something differently, the risk of that knowledge gets transferred to the local processes. So you might find, for instance, that local psychiatrists and psychiatric nurses and carers and whatnot come together and say, we want to change this pathway this way. That then comes to clinical governance, and the clinical governance can have a look at that new pathway. It then goes back perhaps to the PEC, and the PEC might determine yes, and only then does it get published. But then the risk is transferred to the local health community in terms of if there's any harm that results as a result of that localised pathway being proposed.
I would just add just one final point about that is that we believe in absolute transparency, so that if you localise and you can't do the you can't afford, there isn't the resource available, and you prioritise other clinical areas, then that's okay. You just need to express that and be honest about it in your local pathway. Say we don't have that resource, rather than the Daily Mail lobbying and so on. I think it's important to be transparent and open about that.
Just to point that our implementation, we're not using the smart card, we're using a web version, which is linked to a WIL PCT version. So it's a web browser version that you can access from home as well.
Which also makes it easier for social services and local government to come in, because it's just Athens access.
I'm being told to stop now, so thank you very much.
No.
We'll have a short coffee break.
Involved in acute trust and development services, and that's how they actually get people to use it. So we'd like to see more of that.